Okay, so today we're going to discuss all about the blood component preparation. This topic will discuss how the different blood component of the blood here has eventually being produced and some guidelines including their indication for use. Okay, so basically as with with the blood components, so we have here the basic component of the blood that can be prepared out of your whole blood. You could have here your PRBC or the red cell, or the packed red blood cell. We have also here the plasma component and could also have here the platelets. Okay, so component preparation is made here by a subsequent centrifugation process. Okay, you could have here your heavy spin centrifugation at a higher speed and stronger speed and time. That's 5,000 RCF, or your relative centrifugal force, or the G force, for 5 minutes. Then for the light spin, on the other hand, is 3,200 RPM for 3 minutes. Okay, so we have also here the manner of the collection process. So preparation, you could have here the open system, you could also have here the closed system. So you can perform here your component preparation by open system if you have here several na mga satellite blood bag. That would allow you then to produce here your component out of your mother blood bag if you have several either blood bag without opening the entire or without cutting here the tubing. That would render the preparation here as a closed system. So if that one, for example, if you have only a single na a blood bag, then most likely you can have your several component preparation. And at the same time, if you wanted to prepare, for example, your PRBC out of that whole blood, then it become an open system. Once it become an open system, it would reduce the expiration of your blood here to 24 hours. Okay, that because again, that try to expose your blood component to the bacteria. Okay, so when you're doing your component preparation, so like if you wanted to prepare here up to your platelet concentrate, then first you have your whole blood. You try to centrifuge that one with your light spin, that's 3,000 RCF for 2 to 3 minutes. Then eventually that will separate the whole blood to your component na PRBC, and we have the liquid portion, the plasma. So all you need to do is just express that one. So if you have this plasma already, express mo lang to. That will allow the plasma to flow here to your another satellite bag. That would allow here your PRBC to remain on this blood bag. PRBC for this one, you could have your basically 200 to 250 ml. Then the plasma could also be 200 or 250 ml. If this one is 200 ml, you could have here 250 ml, then you could have here 200 ml. Because your whole blood would have a volume of 450 ml. Then if you wanted to prepare your platelets out of your plasma, then it should be subjected to another centrifugation that become your heavy spin. That's 5,000 RCF for 5 minutes. That would allow here the separation of your PRBC. This is your platelet-rich plasma. So, after centrifugation plasma, may mabubuo dito ng mga puti-puti. You can take this one, this become your platelet-poor plasma, and the remaining portion become your platelet-rich plasma. That become your platelet concentrate. Okay, so if you're preparing here for the platelet concentrate, it's being done by a subsequent light spin followed here by the heavy spin centrifugation. Okay, we start with your whole bloods. So whole blood here contains all the blood component. Contains here your PRBC, contains your plasma, contains here your WBC, and even your platelets. Okay, for a whole blood transfusion, basically that's 450 ml. And the expiration of your whole blood will be highly dependent on the anticoagulant in your primary blood bag. Again, as a review, I could have here your CPDs, ACD, CPD, CPD2D would have 21 days expiration. If you could have here your CPD-A1 with the 35 days expiration. Okay, then, the whole blood is basically being used here for transfusion of your increasing the plasma volume. Okay, for the volume expansion for symptomatic anemia with large volume deficit that try to increase both the oxygen mass, the RBC mass, and the plasma concentration, the total blood component. So 1 unit of your whole blood tend to increase your hemoglobin by 3 grams per dl, and every unit of your whole blood tend to increase your hematocrit, the patient, the recipient here, by 3%. On the next one, we have your irradiated whole blood. Irradiated whole blood is being prepared by irradiation process by subjecting whole blood in your gamma with your gamma radiation. So procedure for that, you have your whole blood, you put that one in your canister. So may canister ka, ilagay mo dito whole blood, and then subject this one with your gamma radiation. Okay, 25 gamma rays here at the center and 15 GY here for the other part of your canister. Okay, so you are doing the irradiated whole blood for the prevention of your graft versus host disease. So this will tend, irradiation process will destroy your immunocompetent T lymphocyte. Immunocompetent T lymphocyte is the one causing the graft versus host disease, responsible here for rejection of your blood with your recipient. Okay, and then that's results here to your graft versus host disease. To prevent that one, so you are irradiating the blood to kill or to destroy your immunocompetent T lymphocyte in your donated blood. Okay, for the expiration, so 28 days expiration. Like pag ang anticoagulant natin hindi umabot ng 28 days, like your ACD, CPD, CPD2D, again, they are only 21 days expiration. But after irradiation process, then it still be 28 days. On the other hand, for those naman na medyo like your CPDA 135 days, so 28 days pa din siya. Okay, that's your irradiated whole blood. Okay, the next blood component we have here, the red cell or your platelet concentrate. So basically, the platelet concentrate can be prepared here by component preparation by your whole blood subjecting that one to your light spin. So you need to remove here the plasma. What retains would be your PRBC or your red cell. So for the volume, we have that, but the best time to prepare your platelet concentrate, your PRBC, packed red blood cell here would eventually within 8 hours of the collection process. Okay, in the case of your CPDA1 and either collection tube here, or even your ACD, CPD, CPD2D, or CPDA1, the volume of that should be 200 to 250 ml. That would able to have your retained hematocrit by 65 to 80%. Yung hematocrit here is much concentrated, medyo mataas siya because again, you tend to remove some of your plasma, so medyo malapot ito. But in the case, for example, if your blood has been added with your additive solution, an additional 50 ml should be removed here because of your additive solution. That will reduce the volume here to your 160 to 275 ml, with able to retain the hematocrit here by 55 to 65%. Okay, for your PRBC, again, this one is being used for transfusion in order for you to increase here the RBC mass. Only the RBC mass kasi wala ka ng plasma, not the entire total volume expansion. Okay, the shelf life, so the expiration of your PRBC would be highly dependent on the type of the manner of the preparation here. So if that one is an open system, so if you have only one primary blood bag lang, and then try to remove the plasma, it try to cut the tubing, it become an open system, that one would have an expiration of 24 hours, stored at 1 to 6 degrees Celsius. But if you have your closed system na preparation, so you have your several na satellite bag, you did not open, you did not cut your tubing, then that able to retain here the original expiration of the anticoagulant in your primary blood bag. So again, kung ang anticoagulant mo in your primary blood bag is your ACD, CPD, CPD2D, it would expire after 21 days. And that one has been collected with your CPDA1, that one will able to expire after 35 days. Then we have here the RBC alikot. So alikot lang siya, small volume ng ating blood here. So this is ideal for those baby less than 4 months which require a unit of the blood for transfusion. They require unit of the blood for transfusion because they try to suffer with your fetal-maternal hemorrhage nagkaroon ng red cell destruction because like incompatible ang blood ni mother with the baby with their in terms of the ABO or even their in terms of their RH. So, nagiging anemic ang baby, then the baby requires a unit of the blood to be transfused. When you're transfusing here, approximately only 10 to 25 ml is being given to the baby, not the entire 450. Hindi kakayanin ng heart ni baby pag sobrang dami ang ibibigay mo na blood sa kanya. 10 to 25 ml lang binibigay natin. Kaya tinawag siyang RBC alikot. But the problem with your 10 to 25 ml, so wala tayong blood set na, di ba, full blood, tapos since you're needing only 10 to 25 ml, okay, so paano mo ma-regulate na pumasok doon ay 10 to 25 ml? So, most likely ginagawa nila, they tend to aspirate by your syringe na lang. Kukuha ng 10 to 25 ml by your syringe in the whole blood and then try to inject to the IV line of the baby. So, medyo messy yung procedure. It will have here the chance of exposing the blood and become here an open system. With that, it will have the expiration of 24 hours when blood is being stored at 1 to 6 degrees Celsius. Okay, but when you're performing the blood transfusion here for the baby, so consideration natin, again, ang donor recipient natin should be compatible with their ABO, with their RH blood group, and you should also perform the antibody screen to detect for the presence of your allo antibodies or your unexpected antibodies. Okay, the best one here to give your blood to the patient here for your newborn should be the blood collected with your CPDA1. Although again, additive solution, pwede siyang gamitin for pediatric patient natin, but then the safest one is with your blood collected from your CPDA1 for our infants with a newborn blood transfusion. Okay, the next one, we have here your leukoreduced RBC unit. So leukoreduction is a process whereby you tend to remove some of your WBC with the unit of your blood by the process of leukoreduction by your filtration. So you are using here the third generation filter with the use of your polystyrene or cellulose acetate na filter, where it try to trap your WBC, even your platelets, but not your red cell. So therefore, papasok sa katawan ni patient natin is only the red cell minus your WBC or even your platelets. So quality control, dapat when you're performing, preparing here for the leukoreduction process, the unit of the blood should have less than 5 times 10 to the 6 na lang the WBC counts. Sobrang konti na lang siya. But still able to retain approximately 85% of the RBC mass. Meaning to say, medyo madami pa din ang ating output or yield na RBC out of your whole blood after you try to perform your filtration process. Okay, so saan ginagamit ang ating leukoreduction process? Okay, number one, since this product here try to remove your WBC, this one try to prevent the occurrence of your febrile non-hemolytic transfusion reaction. Your febrile non-hemolytic transfusion reaction is caused here by your biological response modifier or presence in your WBC. Another one, this leukoreduction process or leukoreduced RBC tend to prevent your HLA alloimmunization because your human leukocyte antigen is in your WBC. And another one, since nag-remove tayo ng WBC, this also tend to prevent your cytomegalovirus transmission. Your cytomegalovirus tend to reside in our WBC. And therefore, since you try to remove WBC, it will prevent the transmission of your cytomegalovirus. Okay, we have here two processes when you are performing your leukoreduction. One is your pre-storage, the other one is your post-storage. Pag sinabing pre-storage, so bago mo, nag-collect ka ng blood from your donor, you try to bleed the donor, you collect the blood and then bago mo siya store sa blood bank ref, you try to perform the leukoreduction process. Padadaanin mo muna sa third generation filter natin, okay, and that become your, bago mo siya store sa blood bank ref. That's your pre-storage. By the process of the pre-storage leukoreduction process, you tend to remove the activity of your biological response modifier. Biological response modifier is those are the substances produced by your WBC. They are activated when you try to store the blood in a blood bank ref. Since ito naman, bago mo siya tinago, tinanggal mo na ang WBC natin, and therefore, it will prevent the cytotoxic effect of your biological response modifier that are responsible here for your febrile non-hemolytic transfusion reaction. Your biological response modifier includes your cytokines, interleukin-1, interleukin-6, and your tumor necrosis factor, or also we have here your complement components C3A and C5A. Another method here ay kailan ka mag-filter. Ito naman na-store mo na sa blood bank ref. And bago mo siya i-transfuse sa patient, you try to perform your filtration process. That become your post-storage leukoreduction process. The problem with your post-storage leukoreduction process, since naka-store ng blood na sa blood bank ref, bago mo siya i-filter, so nag-release na siya ng biological response modifier. And therefore, your post-storage leukoreduction process will not prevent the activity of your biological response modifier because it's trying to store, you have stored already your blood in a blood bank ref, which allow the release of your biological response modifier, and therefore they try to cause your febrile hemolytic transfusion reaction prior to filtration process. So, only that, nagpe-perform ka dito ng filtration process right before the blood transfusion. Okay, then we have here the methods for your local reduction process. So you could have here, number one, inline filter attached to your whole blood and then allowing the whole blood to flow by passing through your inline filter. And then it will allow your WBC and even your platelets to be trapped as it try to pass through your inline filters. Inline filter, allowing here the RBC to pass through and drain by the gravity going to the patient. We have your product for that. Another one, we have also your plasma is initially removed, allowing here the remaining portion to pass through with your inline filter. And it would allow further the trapping of your WBC and even your platelets. Another one, we have sterile docking device attached to your inline filters that will still allow that one to pass through with the filter and allowing here the WBC and even your platelets to be trapped. And then allowing your RBC to drain by gravity going to the patient. Okay, next we have here the frozen RBC. So frozen RBC, again, this one is being utilized here for the long-term storage, especially for the rare blood groups. Okay, so the frozen red blood cell here is being done within 6 days. If this one is being collected here with your CPD, CPD2D, and your CPD-A1, and you could also prepare here your frozen red blood cell here within 42 days if that one is being collected with your additive solution. How are you going to perform here your frozen RBC? So first, in preparation for the freezing your RBC, then you need to add here your cryoprotective agent or your cryoprotectant. The cryoprotective agent try to prevent the dehydration by maintaining here the water within the RBC to be preserved. So there are two types of your cryoprotective agent. One is your penetrating. So that's your glycerol. Penetrating here, so pumapasok siya sa ating RBC. Okay, pumapasok siya dito that will allow the water here to be trapped in order for that not to be dehydrated. In order for the RBC to survive even up to 10 years. Kasi 10 years ang ating expiration with the frozen RBC. So there are two concentration for our glycerol. One is 40%, the high glycerol concentration. You start with the -80 temperature and then maximum is -65. We are using mechanical refrigerator for that. Then the low glycerol here, 20%. You start with initial freezing at 196 degrees Celsius and maximum of that is -160 degrees Celsius. -196 degrees Celsius and because here the maximum is 120. Okay, then you are using for that your liquid nitrogen na freezer. Okay, another one is your non-penetrating na cryoprotective agent, the form of your hydroxyethyl starch. This one is not penetrating. They just have here outside the RBC membrane lang siya. Then eventually try to trap your water, still that will serve here as our protective coating or shell that would prevent also here the dehydration of your RBC. So approximately you add 100 ml of your cryoprotective agent. So now if you wanted to use already your frozen RBC, first you need to thaw. The thawing process here is being done at 37 degrees Celsius for 30 minutes in the water bath or even in the running water. Then after that one, you need to remove the residual glycerol here by the process of washing step or your deglycerolization process. In your deglycerolization process being done here by the decreasing concentration of your sodium chloride. You start with a 12%, followed by 1.6, 0.9, and end up with your 0.2% dextrose. If the patient would have a sickle cell anemia or disease, then try to remove the 1.6% because this one tend to rupture the RBC of the patient. Okay, we have your quality control for the frozen RBC. So, recovery here should be 80%. So, dapat 80% of the RBC is still viable. Okay, for that. 80% here. So, 80% of the RBC should be remain. After you perform here the washing step, baka naman nag-wash ka ng wash na ubos ang RBC natin. Okay, we have here the computation of your percent recovery. So, we have here the weight of your deglycerolized RBC multiply with the hematocrit of your deglycerolized over the weight and hematocrit of your liquid RBC. That's prior to freezing your RBC. Multiply by 100, that dapat 80% ang ating percent recovery. Viability here should be at least 70% 24 hours post-transfusion. So dapat nag-transfuse ka ng blood, that RBC is still viable in a patient sample. So mean to say, even if you try to store that one for 10 years, dapat buhay pa din sila. At least 70% of them are viable 24 hours after transfusion. Residual glycerol here should be less than 1%, should eventually have an adequate na washing step, deglycerolization process to remove an adequate amount of your glycerol in the RBC because again, your glycerol is a toxic substance. Once your RBC is circulating your plasma, the recipient dapat wala na siya masyadong glycerol. You should have removed of that adequately by your washing steps. So since you are preparing the glycerization process here, washing step, in an open system, so your wash RBC should have your expiration of 24 hours at 1 to 6 degrees Celsius. Okay, then we have also your wash RBC. Wash RBC here is the RBC which has been washed here by our saline solution. Just like when you are performing your deglycerolization process or washing step. So the washing step here, try to remove your plasma proteins. And the wash RBC is generally used here for the prevention of your allergic reaction or your anaphylactic reaction. Okay, the next one, we have your platelet concentrate. Okay, so there are two formulations for the platelet concentrate. One is your random donor, and we have also your single donor. The random donor platelet concentrate prepared here by your component preparation by subsequent na light spin followed by your heavy spin. Quality control for that contains platelet count of 5.5 times 10 to the 10th and the volume of 40 to 70 ml. And each unit of your, 1 unit of your random donor platelet concentrate can increase the platelet count by 5 to 10,000 of the recipient. Then we have also here the single donor platelet concentrate that was being prepared by your apheresis program. Quality control contains 3.0 times 10 to the 11 the platelet count with a volume of 200 to 400 ml. Okay, and that one could eventually try to increase the platelet count. 1 unit of your single donor platelet concentrate can increase the platelet count of the patient by 20 to 60,000. Okay, we have also here the pooled na platelet. Pag sinabing pooled platelet, ito yung platelet na platelet concentrate prepared by pooling or by combining your at least 4 na mga random donor platelets. So pag kinumbine mo sila, pooled platelets, it would have expiration of 4 hours. Okay, then we have here expiration ng platelet concentrate natin. So that's 5 days at 20 to 24 degrees Celsius or at room temperature. And with your continuous agitation, in order for you to maintain the pH here of at least 6.2, dapat not less than 6.2. Expiration of that is on the midnight of the 5th day. Again, this one is nasa room temperature lang siya, and therefore we considered your platelet concentrate as the most prone to your bacterial infection because hindi siya naka-ref. On the next one, we have your fresh frozen plasma. Okay, the fresh frozen plasma could eventually be prepared from your whole blood, okay, by your light spin. Tapos i-remove mo, di ba? Pag light spin, matitira is the platelet pack RBC. Ang plasma na component, nililipat mo to become your fresh frozen plasma. So, when you're going to frozen the plasma, so if that was being collected with your anticoagulant na CPD, CPD2D, CPD-A1, you need to frozen that one within 8 hours of collection process. But if that one has been collected with the anticoagulant na ACD, then you need to frozen that one. You need to frozen that one within 6 hours of the collection process. For the expiration, so 1 year, for if you try to store that one at negative 18, and 7 years if you try to store that one at negative 65 degrees Celsius. Okay, so your fresh frozen plasma, remember that our fresh plasma contains all your coagulation factors. That's why we use this one for the treatment of your multiple coagulation factor deficiency, or even in the case of your liver disease. Okay, we have here the volume for the component preparation produced here in fresh frozen plasma, approximately 100 to 250 ml. But in the case of your apheresis program, it would have your 400 to 600 ml. We have here the content of your fresh frozen plasma contains your 400 milligram of your fibrinogen and contains also 1 unit of each of your stable clotting factors. Okay, then we have also here your cryoprecipitate antihemophilic factor. So the cryoprecipitate antihemophilic factor here is actually the precipitated protein portion of your thawed na plasma. So after you try to have if you have your frozen na plasma, you try to thaw that one, the precipitated portion of that become your cryoprecipitate antihemophilic factor. Okay, we have here the content of your cryoprecipitate antihemophilic factors. So this would have your fibrinogen of factor 8 of 80 to 120 units, fibrinogen of 150 to 250 milligrams. Medyo madami siyang fibrinogen. Mas konti siyang fibrinogen compare with our fresh frozen plasma because in your fresh frozen plasma, you have 400 milligrams na fibrinogen. This one would only have your 120, tama ba? 150 to 250 milligrams. Another one, von Willebrand factors would have your 40 to 70%, and the factor 13, 20 to 30% of the original na concentration, plus your fibronectin. Okay, expiration, you can refrozen. That one at negative 18 degrees Celsius would have expiration of 1 year. You also here your thawed. So pag thawed lang siya, so that one would have your 6 hours expiration at room temperature 20 to 24. And pag pulled siya, that's would have your 4 hours expiration. Lahat ng mga pulled natin, 4 hours expiration. So we have also here your cryoprecipitate reduce. So if you have your plasma, pag tinanggal mo si cryoprecipitate natin, ang maiiwan is your cryoprecipitate reduce. For example, ito ang fresh frozen plasma natin, tinunaw mo siya, ang concentrated form na is your cryoprecipitate, antihemophilic factor. Ang maiiwan na portion that become your cryoprecipitate reduce. This one contains the following content. Meron pa rin siyang albumin, factor 2, factor 5, factor 7, factor 9, 10, 11, plus your Adams 13. Adam TS 13. Okay, then expiration, you can refrozen this one within 24 hours, stored at negative 18 for 1 year. Or you could have your 6 days expiration at 1 to 6. 5 days expiration at 1 to 6 degrees Celsius or refrigerator temperature. Okay, next we have here the plasma derivatives. Okay, the plasma derivatives products here considered to be the safest na unit of the blood because this one is undergone purification and also viral inactivation process. So our plasma derivatives here could be your pooled na plasma. Pag kinumbine-combine ng mga plasma from different sources. Could also be human source that's being prepared here through your apheresis program. Could also have here your recovered na plasma primarily through your component preparation. Could also have your recombinant technology or your monoclonal antibody purification. Okay, so again, preparation of your plasma derivatives first. With your plasma, you try to remove first, concentrate your cryoprecipitate antihemophilic factor. Pag na-recover mo siya or na-remove, try to perform here the separation of your proteins and try to modify the pH, the alcohol content, and the temperature of your plasma. After that one, you can perform here the viral inactivation process. By the different method, you could have your pasteurization, you could have a solvent detergent treatment, or you could have your nanofiltration. Okay, the first plasma derivatives, we have here your factor VIII concentrate. Okay, the factor VIII concentrate is basically for the treatment of your hemophilia A. So, hindi tayo, for the treatment of your hemophilia A, ginagamit natin yung factor VIII concentrate, not your cryoprecipitate antihemophilic factor. Again, your cryoprecipitate antihemophilic factor is used for the treatment of your fibrinogen deficiency. But pinaka-specific here for the hemophilia A, so you see your factor VIII concentrate. Okay, we have that one. Storage is 1 to 6 degrees Celsius here. Volume is 10 to 30 ml. And your factor VIII concentrate undergone here some preparation. First, pasteurization. Okay, so subjecting that one at 60 degrees Celsius for 10 hours. Okay, you add your stabilizer in the form of your albumin, your sucrose, and your glycine. After subjecting that one to heat, try to remove your stabilizer and try to lyophilize. Another one, to inactivate here your viruses like your HIV and your hepatitis B, then you can perform here your solvent detergent treatment. Our solvent is in the form of your ethyl ether or your tri and butyl phosphate. Your detergent, you could have your sodium cholate or you could also have here your twin 80. And we could also perform here your monoclonal antibody purifications by the use of your hybridoma technology or your myeloma cell. Another one, we have here your serum immune globulin. So serum immune globulin here, concentrated form of your gamma globulin or your immunoglobulin or your antibodies. Primarily, this one is being prepared through your cold ethanol fractionation process. There are two formulations for that. We have the IV and the IM. The IV contains much more of the immunoglobulin compared with your IM. So it will have half-life of 18 to 32 days. So this one is your gamma globulin. So it's being used here for the patient with immunodeficiency or hypogammaglobulinemia. Also used here for as a prophylaxis for those patients with the herpes and the hepatitis. But then again, this one should not be given for the patients with your anaphylactic reaction or allergic reaction, especially having the IgA. Okay, then we have here your plasma volume expanders. The plasma volume expander here is used primarily for increasing the plasma volume, especially for patients with hypovolemia, hypoproteinemia, and even with a patient with a severe burns. The first one, we have the NSA, normal serum albumin. It's made up of 97% na albumin, 4%, 96% albumin, 4% na globulin. And we have also your PPF, plasma protein fraction, 83% albumin, 70% na globulin. Both of that would have here a lifespan of 2 to 5 years, stored at 2 to 10 degrees Celsius. Okay, then we have also here your synthetic volume expander. We have your crystalloid in the form of your normal isotonic solution, primarily made up of your sodium and chloride, and Ringer's lactate, primarily made up of sodium chloride plus your potassium, calcium, and your lactate. Okay, then we have also here your colloid, which includes your dextran, and that one would have here found in formulation of 6%, 10%, with a half-life of 6 hours. Then we have your hydroxyethyl starch, comes in 6% of formulation with a half-life of 24 hours. In terms of the intracellular retention, mas okay ang colloid natin compare with your crystalloid. And then we have also here your RH immunoglobulin. Commercial name for that is your ROGAM. So RH immunoglobulin here is the RHD antibody that has been produced here from someone who's been immunize, hyperimmunize, producing high titer of your RHD antibody or RHD and IgG antibody. Okay, so formulation, we have here the IV and the IM. So the IV would have here 300 microgram and 120 microgram. For the IM, we have here 300 microgram, 50 microgram dose. The 300 microgram dose here considered to be as the full dose. Okay, so one vial of the full dose here, 30. One vial of your full dose here is the 300 microgram, is enough here to neutralize 15 ml of your fetal D positive na fetal red cell to prevent the fetal red cells here to allow it to be exposed to the maternal circulation para hindi mag-produce ang ating mother ng anti-D antibody. So like for example, kung ito ang fetal red cell natin may D positive, ito si mother's D negative. Okay, so para ma-prevent ito na mag-expose ang ating mother, so bibigyan mo siya ng raw gum. Okay, ilan ito? Okay, again, 300 microgram here is enough for the 15 ml, if this one is a red cell. And pag whole blood, that's 30 ml. One vial for the 300 microgram could neutralize para ito ay hindi ma-expose ang mother natin. And eventually, that would prevent also here the development of the anti-D antibody for the mother. Because again, once the mother produces an antibody, RHD antibody, it becomes forever. So problem with that ay dapat palagi na magiging pag na-develop ang mother ng anti-RHD antibody, ang mangyayari niyan on the second pregnancy. Like the first pregnancy, so like for if the mother is RHD negative, ang baby is RHD positive, it's because ang baby natin, ang kanyang RHD blood group is from the father which is positive. So dapat ma-prevent natin ang exposure ng maternal circulation with the fetal red cells na RHD positive. So para ma-neutralize sila, so bibigyan mo sila ng raw gum. Again, one vial, 300 microgram is enough to neutralize 15 ml of RHD na red cell and 30 ml of your whole blood. Okay, then we have also here the administration. So you tend to administer this one 28 days, 28 weeks, okay, prior to delivery and 72 hours after the delivery. Okay, so that's for negative for the fetal red cell contamination. But if positive, then you need to quantitate how much of vial here should be given by computation. Your Kleihauer-Betke is based on the principle here that if you add your sodium hydroxide, it trytolizes your maternal hemoglobin but not your fetal hemoglobin. So, i-measure mo lang kung ilan ang colored na red cells that become your fetal red cells. So, ito yon kung ilang percent ang colored natin. So, that become percentage multiplied by 50, that become here the volume of your fetal-maternal hemorrhage. Okay, then we have your 30. Okay, because again, 30, one vial could neutralize 30 ml. Ay, saan ba yun? 30 ml. Okay, to compute here for the number of the vials, so ito yon. So whatever your result for the computation, you add one vial para really ma-neutralize ang ating fetal red cells to prevent the exposure of the fetal red cells na D positive with your maternal circulation para hindi siya mag-develop ng anti-RHD antibody. Okay, for the miscarriage here, nakunan ng patient natin. So pag less than 12 weeks, you can give 50 microgram dose. But if that one is more than 12 weeks, then you give full dose, which is your 300 microgram. Okay, so thank you.